Hello, everyone. As people come in, gather in their seats here, um, just wanted to thank the Robert Wood Johnson Foundation for helping us out, and not just for helping us like in this room, but also the world doing this work and funding this commission and just all the things that they're trying to do around health equity. Also, thanks for folks joining, all the reporters we were talking earlier. And I think we can all agree, this is basically like the super moon of Fridays. This is like the biggest Friday of the year. So I'm glad for those who are able to join in this moment. What we wanted to do was I wanted to really make sure that people in the media could be introduced to the National Commission to Transform Public Health Data Systems. I had the honor to serve on this commission. And I can just say, just as a reporter, though that wasn't the hat that I was wearing there, as a reporter, the people you're going to meet today, and really all the commissioners, are remarkable sources for you who are really committed to two things. I mean, improving public health data systems, but also fighting the horrible health inequities that are part of living in America, especially for people of color. I mean, it's always made sense to me that if not even the goal of American society should be that your demographic background and your zip code should be irrelevant to how long you live. There's no way that people living 2 miles down the road from other people should live for 2 decades longer. Like, that's just wrong. And it's a broken system, really. And one of the symptoms of that broken system is that we all had to scramble to gather whatever data we could on how COVID was spreading in communities of color, low-income communities, marginalized communities. COVID just exposed how fragmented our health data systems really are and the consequences of that for public health action. But I want to say, this is not just a bummer of a session. You've got people who are really here working to fix these problems. And one major component of that work is what the commission did, trying to lay out the principles and possibilities for better public health data collection. So first, I want to introduce our leader, amazing person, Gail Christopher. Can you introduce the commission and just give us a few minutes on kind of how the commission was formed, how it worked, and what we really hope to achieve?
I certainly can. And Alexis, I love that term, principles, that you referred to, because really what the commission did was to produce a document, a report that helps to charter a course, to lay out the basic framework for what we need to do to literally transform our public health data systems. The commission was organized by the largest and most influential health philanthropy in America, and it was fitting that they would step into this moment. We all knew that this was an unprecedented moment, and as journalists, you know that after every pandemic, major changes have occurred in society. And so we're on the cusp of some major changes, but we really know that our public health system and the story that our public health system tells, the actual infrastructure of our public health system has to be transformed. So Robert Wood Johnson brought together 16 of the most brilliant, creative, dedicated, hardworking people from multiple sectors, multiple perspectives. And I was privileged to be able to direct or lead this process. But the process itself went on for more than a year. Rand Corporation was engaged in gathering just volumes of information and data about the current state of affairs, and that information helped to inform the deliberations. But we knew we had to center equity, and we had to be honest about the role of structural racism in a contemporary sense and in terms of the historic role of structural racism. So we chose to use a framework that's being used across the nation right now to move our country toward truth and reconciliation, some people say, but we say truth, racial healing, and transformation. And that framework has 5 basic pillars: narrative change, building relationships, the social capital, the unity that we require, and then addressing the residual means by which racism has been entrenched in this country and all the inequities that are spawned by that. And those 3 pillars related to structural racism were separation, the law, and the economy. And so the commission deliberated around those pillars and came up with some very bold and creative recommendations, grouping them into three basic categories. The first relates to the narrative change, recommending that we center equity in the public health narrative. And more importantly, that we focus on well-being, that we shift our expectations toward well-being, that we move beyond a deficit frame. And so that's one of the categories that will have a new story that's told by our data. And then, of course, we have to change who governs the data, and we have to make sure community voices are present and have some ownership and engagement. And then the final area of the more granular recommendations speaks directly to the necessity of addressing historic and present day structural racism, capturing the data that would tell those stories, and then capturing the data that tells our progress, that addresses that legacy. So those are the three big areas, but Alexis, I'll refer to you and the other members of the commission, and we were so pleased to have you as one of the key members of this commission to get into the details of the recommendations within those three categories.
For sure, and I'm gonna send it on over to John in a second. I just want to put my reporter hat back on for 1 second and just say, if you ever started talking with a source and you realize that their knowledge both goes like incredibly deep and also super wide, that was kind of my opening understanding of John Lumpkin, who you're about to hear. And John has just done a lot of stuff in this realm and has just a really encyclopedic knowledge. And he's going to address this issue of sort of where does public health data come from in the United States? I know we're like a couple of years into COVID, but I still feel like this actually is not that well understood, even by people who are sort of on the beat. And maybe can also toss in some things about how this is different on a sort of international comparative basis. So take it away, John.
Great. Well, thank you, Alexis. And it's a pleasure and opportunity to be here. I'm going to start off with actually something that happened to me early in my public health career when I was state health director in Illinois. We had two workers, actually clerical workers within our infectious disease division, who were receiving reports from laboratories. And in 1 week, they received 2 reports of Salmonella agona, which is a very rare type of Salmonella. And they took it upon themselves to raise this up and to escalate this and say, hey, something is going on here. We looked into it and we identified and worked with CDC that this was being caused by a toasted oat cereal. And it ultimately played out that this was an outbreak that was tied to this product in 13 states. And as a result, massive quantities of this product was pulled in. And what I took away from this experience was that if we don't use the data that's coming into public health agencies and not just rely upon 2 people having, gee, what's wrong with this? We're not going to have a public health system that fully is able to protect us. That if we don't have a system that automates the flow of data from laboratories and from hospitals, that we won't have a public health system that can respond. 25 years later, I'm here in North Carolina, and public health is still receiving reports by mail and fax. And not only that, but we also understand that there are many factors that impact the health of individuals and the health of communities. And so as we think about public health data, it becomes a much broader issue. We think about the data that we get access through in clinical settings, reports of infectious diseases, but also reports of overdoses or cases of cancer, so we can identify cancer clusters. All of those are brought together, they're aggregated by public health to look for the patterns that can help us better understand and not only predict where we can have impact, but also predict trends. Public health also has public health derived data. This includes data from surveys, so we can begin to understand the health challenges of communities. And this is done at both the federal, the state, as well as the local level. Public health also gets data from public health laboratories. In rural areas, it's very important to check well water, especially when homes are transferred, or cases of very rare diseases like rabies, which are only done in public health laboratories, or doing the DNA fingerprinting when there's an outbreak so that we can see that maybe this case and this case might be related. Measuring lead in homes to determine if this is why a child may be having lead poisoning, because lead is still in the paint on their walls in their homes that are very old. And also looking at data on communities. How easy is it to access healthy food, or what's the state of housing, or the transportation access, which can have a big difference on whether or not someone can make it to a prenatal appointment, if in fact the appointments are scheduled in contradiction to the bus routes and the bus schedules. All of these are of public health significance. We have seen a lot of significant developments in data management in this country, in health data management. But as William Gibson, who's a science fiction writer, said about 20 years ago, the future is here. It's just not evenly distributed. So as we think about public health data, we're looking to get data from healthcare and many other sources. And there are some ways that really point to the future. There's a system that CDC has implemented for COVID and can be expanded to many other public health purposes, called ECR Now, or Electronic Case Reporting Now. But unfortunately, this is only in large health systems, because we don't have a way to get them into smaller health systems, into smaller practitioners, which are the same practitioners that provide services to communities that are most impacted by the disadvantages we see in our society due to income, due to race, due to geography. We don't have standard ways to move data from one system to another, and all of these are in the works, but we need to accelerate them. So this is the kind of issue that we talked about, but I want to add one more, and that's the collection of race, ethnicity, sexual orientation, gender identity, income, and ability data. And far too much of our systems are relying on imputed data. By imputed data, I mean based upon an individual's zip code, where they live, income data around that. We're going to guess that you are white, that you are Black, that you are Asian, that you are Latino. Yet our own data inside Blue Cross has found that much of that imputed data is at best only 70% accurate. So we need to enhance the collection and use of data that is reported by individuals based upon race, ethnicity, gender identity, and income. Public health data needs to be meaningful and actionable at the community level to assure that communities have a fair opportunity to be as healthy as possible. And then it will be relevant when it's rolled up to the state and national level. Back to you, Alexis.
Thank you, John. That is the problem set right in miniature. I want to just highlight a few things for reporters out there. One, so many types of stories actually need public health data. Your environmental justice stories, your housing and urban design stories, things about the opioid crisis, or what we see in San Francisco, fentanyl, comparative stories between cities, anything about like sort of quality of life. And so many things about structural racism all sort of like require this public health data. And yet that's kind of perched on what remains an incredibly fragmented and manual system. At the same time, an exciting journalistic thing is that this particular moment, both because of the protests after George Floyd and Ahmaud Arbery in 2020, as well as because of COVID, there really is a moment of transformation that is trying to happen. And I think there's probably a whole bunch of features in exactly how that's happening in different places. And I think right now I'm mostly hosting a radio show, but if I were writing features right now, that's really what you'd want to go after. And I think that that systems change is going to be the backbone of a lot of really, really, really big stories. And it can be tied into the issues that are most relevant in the communities that you're reporting on. On to the next one. I really had pleasure of working on a subcommittee with Michael Crawford of Howard University. He's a brilliant man, really with a really unique perspective on the issues that we face here. And Michael's going to tackle this question: how can public health data be improved, especially to pick up kind of new developments, like, for example, I don't know if he's going to address this super specifically, but for example, the Omicron variant. Michael.
Thank you, Alexis. And thank you everyone for attending the briefing this afternoon or morning, wherever you're located. It has been an extreme joy to be a part of this commission and work on a project that is so meaningful and transformative for so many communities. Just to build on a couple of comments that John mentioned around public health and as reporters thinking about stories that make sense and about changing the narrative, which was the subcommittee that Alexis and I worked on. I think back to early on in the pandemic when public health departments and philanthropy were establishing community-oriented testing. And most of those testing sites were drive-through testing sites at the time. There were no sites really in implementation or in communities where you could walk up and receive a COVID-19 test. And when I think about how those decisions were made, they were made based on data, right? And the data that was available, folks were making decisions about how they allocate resources, how they stand up and operationalize a community-oriented testing site. And through that process, what failed to happen immediately for the communities that were disproportionately impacted by COVID-19 in terms of positivity rates and deaths, they did not have access to testing, because some of the folks in those communities do not have access to a vehicle. They only had access to public transportation. So thinking about how the story has been told around COVID, and I think Gail alluded to it early, we need to think about equity through the lens of how we're communicating and sharing and using data, which is a source of truth, to be able to put forth information and narratives to the public. And that's one thing that we worked on and thought through as a fundamental concept that needed to change as we think about how we transform public health data systems. The other piece is, how do we identify stakeholders that are being disproportionately impacted by COVID-19 and other elements, and how do we bring them to the table from a perspective of participation and engagement? And need to do that through a very thorough stakeholder analysis and identifying who are relevant to this ecosystem in creating the future public health data infrastructure, with an emphasis on equity, with an emphasis on community-based organizations that are on the ground level and dealing with these issues day in and day out. And then once you do that, how do you build a model, a competency model? Because what we found in COVID-19 is that there was a deficit in terms of how you analyze data at the community level, at the faith-based level, even in our public health departments, that the skill set and the competencies were not there in order to be able to analyze the data, standardize what we wanted to capture, collect, and use, and then also look at some of these pain points and interoperability challenges that we've all faced at the local as well as federal level. And then how did we take all that information and really develop a way in which we could train those folks? And working in an academic institution, it's a great opportunity to take some of these recommendations from the report that we've identified and try to inculcate them into a curriculum where we can start to build up the workforce from a professional perspective. But then how do you create certificate programs and alike that allows community-based organizations to be credentialed in a way where they can analyze data and use this for program development, service level delivery, et cetera. From an innovator perspective, what we thought about in this report, innovators can't develop new tools and solutions unless you're operating from a base of truth. And if the data is not clean, the data is incomplete, you're developing solutions that only can be generalized to larger populations. You'll never really be able to transition to a granular level and to be able to develop solutions that align with the needs of the community and the end users. And that's also on the provider as well as the patient side. So as we thought through changing the narrative, orienting equity into what we do, looking at how do we include the stakeholders in building out this new public health data infrastructure, and then what are those competency skill sets that are needed to make sure that we have the workforce and infrastructure to support sustained development. And lastly, how do we give innovators a fair shot at being able to develop new solutions that will address the next pandemic and then foster and accelerate health and well-being for all communities.
Michael, that was awesome. I can highlight just another couple points there again. I mean, just returning to how much information we were tossing away through the whole testing process, particularly in those early days. It's truly painful to watch. And I think data about race, ethnicity, income, occupation, things that Michael was talking about, the things that John was talking about, they're of course important to help protect marginalized communities who may be experiencing the effects more than other places. In fact, we know that that was the case. But it's also super important for tracking the overall spread and arc of an outbreak, whether it's COVID or something else. Excluding some people for various access reasons, biases the data, and not collecting all available information kind of handicaps our ability to do analysis and to really quantify the disparities between different communities. And it's tough. Margarita Alegria, she's really your top shelf source for trying to measure, quantify, and maybe eradicate health disparities. She's at Harvard. She's going to tackle our final question before the Q&A section, which is, how could better health data help address the deep injustice represented by racial health disparities? I think you're muted.
Yes, thank you, Alexis. And thank you for this opportunity to talk to journalists, because I think one of the areas that we know is there's a huge gap between the data collected and the data disseminated. So one huge aspect of this transformative effort is really bringing back the data to communities. It's really working with communities to make sure that the goals of the data collection also are in line and in alignment with what community needs to also make their own decisions. I think we've always think of data at a very governmental level, but this is bringing data to partnerships with community, with government, with technology, so that we can accelerate, like Michael and John have said, the process of an underfunded system that has been doing the best it can, but sometimes with such limited technological support, with such limited, new ways of analyzing data. And this is bringing it to communities that typically do not have these resources. This is what's very different. Initiative to work with communities to make sure that the Voices community has a big, opportunity of coming to the table, that we're shifting from not only do correlations between race and outcomes, but actually include some of the structural causes that could be tied to that correlations, so that we can do some prevention or treatment or policy change that before sometimes we're not able to do. Many of the times, we have data and it's descriptive, like John was saying, but we don't really can explain what's happening, what's behind it, because we're not collecting the variables of structural racism that might account for that. This is a new, different approach. We're really bringing the voices of experts, the voices of community that can contextualize what's happening in their communities. What variables have we not collected that we need to collect to really make contextually and historically based information that might help us understand what are the preventive things we can do from an asset perspective. The narrative on many of these communities, and I can tell you working for many years with communities, it's a very negative, it's a very, very negative narrative of communities that are disadvantaged, that are low income, that are poor, that have low health literacy, that are vulnerable, that don't come to care, that don't want to be tested. No one's looking at the mistrust No one's looking at all the things that for decades these communities have felt. And so bringing the information back to them, being transparent in for what we are doing, what is the equity focus? And I think one of the most important aspects that we are going to be able to do is really evaluate, are we doing changes? Are these changes having an impact or not? We have a lot of initiatives that people talk about, how we are going to deal with these disparities. But we have very limited evidence when it works and when it doesn't. And this is one of the biggest aspects that we will be able to do with the way that we are charting this new approach. So I'm going to leave it at that because I'm sure that we want to give opportunity for the journalists to ask us questions, but I think it's an extraordinary opportunity to move and shift what public health systems are doing. And I want to end saying that I take my hat to public health offices and to the people that for years have been struggling with limited data and doing the very best they can with an incredible commitment.
Yeah, absolutely. I mean, local public health people have been heroes through this whole, well, for a long time, but I think people have come to really recognize that over the last couple of years, just unbelievable commitment under unbelievable pressure as well. If you want to ask a question, and Mona's dropped in a little link to, there's a big report. You can get in touch with me if you need some pointers to things that might be of interest to you. You can ask questions. You can do it through that Q&A function there if you're interested. If not, I can also ask a couple more things. I'll give people just a second. Maybe we'll start with this while people are thinking about it. John, have you seen, like say during your time as, being state health officer in Illinois, have you seen any kind of moments like this where it felt like we really could do things in a different way? Or does this feel like it's kind of an unprecedented moment in public health data systems?
I think I'd have to respond by saying yes. In that, in 2001, much of the focus has been, and as appropriately should be, on the attacks on the Twin Towers and the Pentagon. But that October was the anthrax attacks. Mm. And there were huge amounts of funding that went into public health. But it didn't go into the data systems. It didn't result in a dramatic change in our ability to get the data to allow public health agencies to make the right decisions at the right time. And it certainly didn't go into providing data for communities to make the right decisions for them as they seek to be healthier. I think we have another pivotal moment here where we have all as a nation begun to realize how the underfunding, the chronic underfunding over decades of the public health system needs to be remediated. But it needs to be remediated in a way that centers equity and understands that the technology that's available in this one of the leading information technology countries in the world should be applied and should be in place for the system that keeps our people healthy.
Yeah. Gail, when you look at this country kind of broadly, how much of the problem, just based on the work of the commission, is this about that we don't have a national healthcare system? Or is it that there, how would you sort of say, this is why we have this set of these particular sets of problems? Like, here are the big American factors that have sort of landed us in this place.
Wow, that's quite a question.
Well, there's some, you can just sum up the commission in a minute or two.
Right. I would say a lot of this is that we don't have a fundamental commitment to people having a right to be healthy in our society. And a right to be healthy encompasses access to care, but it also encompasses the social determinants. people have a right, all people have a right to live in communities that are conducive to creating health and well-being, because the conditions for health and well-being are there. And so that combination of tensions in terms of not really believing or framing that health is primary to the viability of a democracy, when you couple that with our legacy of hierarchy that we believe some people deserve and other people don't, then that is a major sort of, it supports this reticence, if you will. Now, my colleagues who are deeply immersed in the systems of healthcare and public health, on a daily basis, they could attribute it to, and it is terrible. I mean, we're talking single-digit percentage points, low single digits for the investment of our huge healthcare bills annually into public health. We just don't. We put 3 to 5%, into public health. All of the rest of the money goes into pathology-focused disease care. We need that, but the evidence is very clear that our investment is not getting us, in comparison to our peer nations, it's not getting us the outcomes that we need. And I think COVID, because it had such a disproportionate impact on people who already had chronic disease burdens and chronic stress burdens, it sort of pulled the covers back and said, wait a minute, what can we as a country do to become a healthier nation? And if we do that, we have to have information that guides that transformation. And that's why I was so honored to lead this commission and to have brought together so many critical thinkers and doers, not just thinkers, but real practitioners who understand the complexity of the challenge holistically. But a piece that shouldn't leave this discussion is the importance of us, and John alluded to it. We have to do collaboration beyond our own sector. We have to leverage the technology that's there now. We could have a totally different healthcare data and information system within the next decade, but we have to go outside of our silos and really leverage what's possible.
Yeah, we've got our first question. I'm going to let the commissioners fight over who wants to answer it. Jackie Mark Maloney asks, I think we can all agree that public health data should be collected, shared, and used more systematically. What specifically is in progress to improve this, and what more do you think should be done?
I'll take the first run at the question. And one of the things that we do have in place is we have a fairly robust health information exchange infrastructure in place that supports our public health departments in regions throughout the country, where they exchange and collect data. And
who's in the health information exchanges, just for those who are?
So the health information exchanges, I'll use a practical example in our area. We have a regional, what they call HIE, where there's data feeds from the health systems, from providers that feed data in to these HIEs that serve as data repositories to collect health information, right, on patients. One of the HIEs in our area is called CRIS. CRIS, during the pandemic, was instrumental in being able to track and send out notifications related to COVID-19. They were probably one of the cutting edge, innovative HIEs in the area that really was well positioned to support the data collection, sharing needs of the region from a COVID-19 perspective. If you look across the country at other health information exchanges, I don't know if they were in a position or as advanced or resource to be able to support the needs. So I think Gail alluded to this, resourcing some of these different health information exchanges, having the right leadership and competencies in place helps in terms of being able to support some of these emergent and future needs of the country from a pandemic and a health and well-being perspective. So we do have infrastructure in place. Now it's taking some of the thought and recommendations from this committee and others to really elevate and augment some of those efforts to make sure that we are appropriately and robustly responding to the needs of communities and states.
I wanted to also emphasize that there are things that are being done now more than ever. One is accountable care organizations are collecting now data on social determinants, and that data is being used in partnership with health data, which is amazing. This is a big change, and that is all across standardized formats for collecting the same types of data across all accountable care organizations. That is going to be a big move, in terms of being able to tie, what are things that are important to make sure that we buffer, because they will have tremendous impacts in terms of our health outcomes. So I would say there are things that are being done. I'm going to let John also chime in.
So I think that there are, and I agree with the other panelists, that there are things that are being done, but there is a real challenge that the nearly $1 billion that's going to be available for data modernization will be squandered. And that's because, one, the data standards that we do have may not be followed. So if we have every single state using data standards that are different, they won't be able to share that information in a meaningful way. We have to be able to move data out of the electronic health records into the public health system, again, in a standardized way. This is a time when developing our own standards is not innovation. It, in fact, impedes innovation. Innovation will occur on how those standards are used to enact a better public health system. And then finally, we have to think about ways that this could be done in an equitable way. Some public health systems have a lot of resources, but most in my home state of North Carolina are small. They're in rural communities. 80% of the counties in North Carolina are rural, and they don't have the resources. The healthcare providers don't have the resources. And then lastly, and I know I said almost lastly, but there are needs for new data standards. And I would point out, for an example, where that can happen. There's a initiative, HL7 is one of those national standard development organizations. And there's an initiative under that called Gravity. And they are developing the standards for social needs, which right now are recorded in so many different ways in electronic health records, so that we can pull those information from different electronic health record vendors together. So at the community level, at the city level, at the state level, and the national level, we have data that can fit together and give us the picture to enable us to help our communities be healthier.
I just wanted to emphasize something that John said, which is, really, if you're looking for some big stories around this, I mean, data modernization money flows through the CDC, I believe, right? It's like their actual initiative. Definitely take a look into that. I mean, it's going to be one of those things where, like, when we look out 10 years from now, we're like, what happened? This is the moment right now where having like a lot of eyes on what's happening in that process would probably be pretty helpful. And it's a really, I think it's one of those things that's going to be shockingly important down the line. And so you can get ahead of that on some of your stories. And I think the data standards are one of those things that if you're not someone who works with data day in and day out, you may not recognize like how important those really are. But I mean, it's as important as, like, as John said, like if different states adopt different data standards, you can't have national numbers. I mean, it's like that basic. And when I started, going deeper and deeper into this through the COVID tracking project, one of the things that we kept noting was like these states and even counties within states are just kind of doing different stuff. And every time that happens, it throws off your ability to do the analysis that helps people actually understand what's going on. I mean, that's really what it comes down to. Bad data standards equal less understanding of actual real world phenomena.
And let me just give a quick example on that. In the United States, one of the strengths that led to our industrial growth was our railroad network. Very early on, the United States settled on a distance of 4 feet and 8 inches between the rails. If they hadn't done that, you would not be able to go from one state to another on a railroad card because it wouldn't fit the rails. And we're just looking for standards within our data systems that allow us as a nation to use our data to the best advantage.
And
Let's-
I wanted to add,
Oh.
I wanted to add one thing about, the importance of the aggregation of data that's beyond health data. I think some states are doing an amazing job, and I'm going to use Massachusetts, who's been able to aggregate not only data of health, but education, public services, social. So we can then look at not immediate outcomes, but actually the compounded effects of different events that happen to people and how they affect their late outcomes. So I think we're doing amazing things, but it really depends on states that have more money in an investment that they can do with states that have very little money to be able to do this work.
I think we'd be remiss, Alexis, if we didn't point to the fact that this administration, this current administration in Washington, D.C., is fully committed. They have put equity at the center of their data efforts and work. And so it is a window right now that I believe is unprecedented. And the journalists should be aware that there is a real push. They have the report. We've had interactions with the White House. And so this is a time where there's a possibility that not only what's happening at the state and local level, but there could be federal, support behind it in ways that we haven't seen before. And we are in touch with the CDC. So yes, this is a rare moment.
And Alexis, can I just add one more point? As we even interview and work with startup companies in the digital health space, a number of their business models are oriented around equity and social determinants of health, which we haven't seen a lot over the past several years. So even some of the new digital health and cutting edge solutions are grounded in equity with an emphasis of addressing some of these healthcare disparities and social determinants of health with a real business focus. So we've seen a lot of fervor and energy in the startup space as well.
Let's take this last question, and then we will release everyone into their holidays. Matthew Albasi, I hope I said that right. What are the commission's views on using data from private companies to supplement the areas where public health data is deficient?
So I'll lead by saying that we did have private companies represented among the commissioners. And so this notion of cross-sector collaboration and partnership was built in, I believe, to the recommendations, with an understanding, though, of the critical importance of protecting privacy and all those nuanced issues that where people are not exploited. So we understand that the private sector is far ahead of the public sector right now in terms of capability and flexibility. And so there will be need for partnership. But there was also a really important understanding of the risks that are associated with that. So that would be my non-answer.
No. It just points to the importance of governance, right? I mean, I feel like that came up a lot on the commission with like data governance, and when you're incorporating data from places that may have different standards of governance, it gets complicated. Any of the other commissioners want to take on any on that there?
I think I will add a couple of points. One is that we shouldn't let the perfect be the enemy of the good. Yeah. In a number of instances, data that's available from these private companies can be useful in communities, can be useful for public health agencies. But there's always a caveat. Frequently, the data that comes from these communities are imputed, and I talked about that earlier. So they estimate what an individual's or a community's race or income will be. They are really good for doing planning. They're not good necessarily for designing interventions. But one of the recommendations from the commission was that philanthropy should fund gaps in public health data, particularly for communities with less resources. And so we did think about that. We think it's an interim step. And as communities get better in collecting data, and maybe these private companies get better in collecting data, it's certainly something that we should look at as that partnership that Gail talked about between public agencies, private companies, and communities.
I think that the commission was really very interested in this issue about private-public partnerships, but also about making sure that the data was used for, for a good purpose. I think the mistrust in some of our communities has a lot of legitimacy. So we wanted to make sure that there was transparency of when the data was being used and how, for what purpose it was being used. And then the issues of protecting confidentiality of the user. So I think the commission was very, very interested in this partnerships, but caution about how to go about it.
Yeah. All right, I think we will probably leave it there. 45 minutes seems like just about the time when your eyes start to glaze over. So that's perfect. And, we do have a whole report. As I said, Mona Elkaban dropped in a link to it there. There's a lot more detail there, as well as in a series of other collateral things that we've produced around the commission. Again, you can also feel free to get in touch with me. You have my email address because I sent it to you. Sent you this invite. And I just want to thank one more time the commissioners and Robert Wood Johnson. I mean, it was I knew I was out of my depth with y'all when I showed up, but then I really found that out as we went through the process. So thank you so much for teaching me and everybody else and sharing your knowledge. We really, really appreciate it.
Thank you.
All right. Have great holidays, everyone.
Happy holidays.
Happy holidays.
Happy holidays.
Talk to you later.
Thank you.